Good evening, everyone. At the outset, I want to thank Dr. Reddy, Dr. Rajgopal, and the team for giving me this invite. I also want to congratulate Dr. Charles for the wonderful presentation. He made the job of this case presentation very easy. So on the foundation, I want to present this case. It's a big challenge for all of us. So this is a patient of a 49-year-old gentleman presented with history of fluctuating non-cholestatic painless jaundice of 8 months duration and abdominal distension for 7 months. He was evaluated elsewhere and found to have liver disease. Abdominal distension was incidence and onset gradually progressive, associated with pedal edema. No history of fever, decreased urine output, hematemesis or altered sensorium in the history. History of blood transfusion for anemia for 5 months before. He was a chronic ethanol consumer with last intake 8 months before. No history of any CAM, no history of childhood jaundice, no significant family history. Comorbidities, he was a known case of hypothyroidism on 50 microgram per day. So this was the labs at presentation in our institution. HB of 7.7, total count 6,400, platelet count 98,000, bilirubin 1.7, albumin 2.3, sodium 122. Etiological workup was negative. Room air ABG showed PO2 of 157. Tumor markers were negative. Endoscopy showed small varices, mild PHE. Ultrasound showed shrunken liver, no SOL, gross ascites. 25 urine creatinine clearance was 60. Thyroid functions was 9.16, so it was on the higher side, so the dose was increased to 75. Acerbic fluid showed high SAG, low protein, no SBP. Coming to the anthropometry, this was the patient. He was grossly sarcopenic with a distended abdomen. His hand grip strength was only 15 kgs. His liver frailty score was 5.5. He was severely frail. And his psoas muscle index, if you see here on the right side, it was very thin psoas muscle. The psoas muscle index was 2.69. The normative value for this age group comes around 4.7. So diagnosis was a case of portal hypertension, non-bladder, small varices, cirrhotic, ethanol related, decomposition with ascites, refractory, diuretic intolerant, acute kidney injury, HRS, AKI, severely frail and sarcopenic with a hand grip strength of 15, psoas muscle index of only 2.69 and liver frailty index of 5.5. So coming to the panel, can you consider transplant in this patient?
So in this patient who is cirrhotic with refractory ascites and complications in the form of AKI, HRS, definitely transplant is indicated. However, the challenges remain in the form of severe frailty and sarcopenia, which is again associated with poor transplant outcomes. However, even in frailty and sarcopenia, waitlist mortality is very high, almost around 50 to 20%. And hence, with good rehabilitation and nutritional optimization, I would definitely offer the patient liver transplantation, explaining the risks of prolonged stay, risk of infections post-transplant, poor recovery, etc.
Dr. Chaitanya?
Even I agree to that, what Dr. Manasa was saying. I think once we have considered this patient as severely frail, it is better to prehabilitate him and then take him to at least admit him in the hospital, do a prehabilitation, and then improve his muscle power as well as the nutrition, and then only consider for transplant. Since we know that the risk of mortality is high, if you take these kind of patients for transplants.
So you prefer to list him for DDLT?
Yes, I would actually, and I'm not sure whether tips will help in this patients to, since it's a refractory ascites and no history of HE, so we didn't find any shunts also. So maybe tips will stabilize him a little, and then the nutrition also can improve a little more in the meantime.
Okay.
I have a slightly different opinion. Tips, I would be a little skeptical in this patient with severe frailty and sarcopenia. considering higher risk of post-TIPS encephalopathy in a severely sarcopenic patient. So I would consider also upfront liver transplantation while optimizing the patient.
Absolutely. I'll not go into this, already covered by Dr. Charles. So Dr. Shweta, this is your study. If you can educate the audience on the normative values in the Indian population.
Yeah, so we did a study to see how the cutoffs were different or were they the same, because it was there was literature to suggest that the patients, there was a study from ILBS, and I was a part of that also, in which we used Western cutoffs, and so a huge number of our patients who were going for transplant had sarcopenia. So we thought that, Indian patients having a different muscle mass and different dietary practice, generally we are not so well built. So we should look at our cutoffs. And so we recruited our population from the hospital, the employed people, as well as the donors who were going for, who were getting evaluated for transplant. So we included 500 odd people for assessment of hand grip and functional tests, and for skeletal muscle assessment, we included the healthy donors, and we...
And the liver frailty index also.
Yeah.
So this is an important study for everyone to read.
Yeah, and we found that the cutoffs were quite low, and
Yes.
these corroborate with
Compared to the
others.
Western data, it was lower in the Indian population.
Yeah.
Coming to the pre-op assessment, Dr. Shweta, you want to give any inputs how to assess these patients for transplant? When,
If this patient is going for a living donor transplant, I think the maximum confidence comes from looking at the donor. Because this patient is so debilitated. If the surgeons feel that they are getting a very good graft, I think that actually decides in favor of proceeding for transplant. And deceased donor, I think being not, since it's not a split graft, perhaps the same.
So as alluded by Dr. Charles, so this is it's a vicious cycle. So as the patient increases sarcopenia, increased frailty, they have more symptoms of more symptoms of portal hypertension, and as the symptoms of portal hypertension increase, the sarcopenia also worsens. So in this patient, during our hospitalization, he presented with AKHRS, and then he developed hepatic encephalopathy. He had refractory ascites, diuretic intolerant. He was so sarcopenic with frail that he was not able to converse and tell his name also during the hospitalization. So, do you think it is futile for transplant, Dr. Chaitanya?
Definitely. I think at this point of time, so I think there is a lot of risk after the transplant also. Post-operative complications in frail patients, in a study has been said that almost like 59% to 35% in frail versus non-frail patients, as well as the liver failure rates are also, graft failure rates are also high, come somewhere around between 21.5% to 4.9%, a lot of difference between them. So considering these things, even the mortality, HR index which suggests the mortality of these patients also are significantly high. So I think considering transplant at this point of time is not a great idea as my concern is.
Dr. Shweta, what do you contemplate issues intra-op and post-op in this patient if we proceed with transplant?
Actually, you're asking me about intra-op, but I think pre-operatively I'm more afraid of hepatic encephalopathy, and this patient waking up as it is. You're saying he's not able to even tell his name, and post-operatively, of course, weaning from the ventilator, perhaps.
So this was the palliative care. I think this patient should be in palliative care. If it is in a DDLT setting, this patient should have been palliative care because, as rightly said by the panel, it's unfit for DDLT listing. So preoperatively, he was severely sarcopenic and frail, refractory ascites. He had chronic portosystemic encephalopathy, acute kidney injury with HRS, prolonged hypotension needing low-dose inotrope. Because he was so frail, he was not able to feed. So he was placed on NJ because RT was not tolerated, and daily chest and limb physio also was done. Now here, there is some new data coming up. Even Dr. Kaushal Madan also asked about this. about role of giving testosterone supplements in these severely frail patients. So this recent data published in Clinical Gastroenterology Hepatology, whereby giving testosterone in these patients cirrhotics with hypogonadism, it has shown to improve, reduce mortality, reduce the risk of new onset, new decompensation events without increased risk of HCC. There's also some data about home-based frailty interventions using this home exercise equipment and remote frailty assessments, wherein by these interventions, by physical rehabilitation, the liver frailty score also improved in these patients. So this was our patient's chart during the hospitalization. You can see here the creatinine increased to 2.6 and then it gradually improved on low dose inotrope, but patient was continued on low dose inotrope because of the low mean arterial pressure. So we explained, we had a MDT in the team and we explained the risk of high risk to the family due to the poor functional status and risk of intra-op events and prolonged hospital stay and risk of infections. And family consented and we proceeded for living donor liver transplant. His wife was a donor, so this was standard right lobe transplant, but also feeding jejunostomy was done in this patient. So he was shifted to the liver ICU with a support of 40% and NORAD and terlipressin. He also underwent tracheostomy intraoperatively. So do you agree, Dr. Shweta, about early tracheostomy in this patient?
Yes, it does help in suctioning and you can assess the patient's response.
And because his his respiratory effort was so poor that we couldn't have extubated him post-operatively.
He was anyways a candidate who might require, and all these surgical complications would prolong the stay.
And as rightly said, he also had post-op bleed, for which he underwent re-exploratory laparotomy and was found to have hemoperitoneuria with large intraparenchymal hematoma. After packing, it was after 48 hours again he was re-explored and the packing was removed. He was started on trickle feeds, FJ feeds, and then increased the feeds. So how do we approach immunosuppression in such patient? This is something very challenging because they're so frail and prolonged hospital stay pre-op. Do we believe in giving delayed immunosuppression or anyone?
I would go with, along with the nutritional rehabilitation, I will also start immunosuppression, but slightly on the lower dosage with regular monitoring and also while monitoring the side effects.
So as rightly said, we delayed the immunosuppression, we gave very low doses. He also had one episode of ACR which he improved with regular chest and limb physiotherapy. Tracheostomy was decannulated and he was discharged on post-op day 20. So this was his blood work. We started with a TAC level of 1 and gradually built up till 7. So take-home message, this was a very challenging case, sick, severely sarcopenic and frail patient. Preoperatively, he received aggressive feeding with physical rehabilitation. He underwent timely living donor liver transplant with earlier tracheostomy and aggressive physiotherapy, gradual and low immunosuppression. One take-home point here was feeding jejunostomy helped this patient post-operatively, and also he always had a clean chest. There was no chest infection. That was one of the important predictors of this patient's post-op survival. So this is the patient. He recently went to Kumbh Mela also, and he's doing well. He's resumed his work, and his wife was a donor. They are living a normal life. Thank you very much.
I think what I want to emphasize in this case is that early intervention and rehabilitation should be started in cirrhosis patients rather than waiting for intervention until they are severely frail. And also earlier listing for DDLT and liver transplant should be offered at an earlier stage before severe frailty sets in for better outcomes.
Prof.
A very rewarding case, I must say. But I think physiotherapy is extremely important.
Yes.
Pre-operatively, not giving up on these patients, hauling them.
So they were quite motivated. We explained them the risks of intra-op and post-op, and we had to convince our anesthesia team also. They were very worried, But in the end, I think the wife said, whatever risk be, I'm ready, because they had twins and young family, small family. So it was more of emotional decision, and actually he improved. It was very learning for us, increased our hope also.